Dr. Amber Bourgeois is a nurse practitioner at BC Cancer and just defended her PhD from the University of Victoria on Thursday last week, I think. University of Victoria School of Nursing. I have had the incredible pleasure of working with Amber for the last 5 years, which I think started during my own postdoc. And we like really immediately connected on our shared interest in oncology nursing, passion for health equity and social justice. And we've had so many meaningful conversations over these years, literally all over the world. As we've collaborated on different projects and shared in a lot of the challenges of doing research in this space. Um, so yeah, having watched Amber complete her PhD over these last few years, I am really, really excited that she's here to share it with us today. I'll read the rest of her more formal bio. Informed by critical and intersectional perspectives on health equity and social justice, Amber brings her clinical experience as a nurse practitioner to examine inequities in accessing cancer care in real-world settings. The focus on her dissertation research, which we're hearing about today, aims to identify and understand barriers and facilitators to accessing cancer care treatment and care from the perspective of people who experience socioeconomic disadvantage, including poverty and homelessness, their caregivers, and community-based support networks. So, with that, I'm going to hand it over to Amber to talk to us about her work.
Thanks so much, Tara. Yeah, before I start to share my screen and the more formal presentation, I'm just so excited to be here today. I haven't been able to attend because I have literally been under a rock for the last year trying to get my dissertation done. And as you can imagine, when you're working in clinical practice and also doing, yeah, a dissertation, you just have to say no to so many things. So I'm just so excited to kind of emerge back into a community of people that I know are working towards the same goals that we all have. So that's really exciting. So I will share my screen. All right. Okay, so yeah, today I'm going to be providing an overview and it'll just be a higher level overview for the sake of time towards advancing health equity in cancer care, understanding the barriers to accessing cancer treatment for people who experience structural vulnerability in Canada. And I'm happy to hear that I'm in good company as people are also working on various projects at this intersection. And before we get started, I'd like to take a moment to acknowledge with respect that I'm here on the lands of the Lekwungen peoples, on whose territory the university stands, and the Wasanic peoples whose historical relationship with this land continues to this day. And because we are gathering over Zoom, I think that Tara also kind of put this in out there, but just to put in the chat if you would like to from the lands that you may be coming from. And while we are on the topic of barriers and in recognition of the Truth and Reconciliation Commission of Canada's call to action 18 through 24, which pertains to health inequities, I acknowledge that the current health inequities experienced by Indigenous peoples are a direct result of ongoing colonial structures and policies. And in my work at the cancer system and in research, I'm committed to advancing reconciliation through listening and learning from Indigenous voices, respectful engagement with Indigenous communities, and confronting systemic racism in healthcare and academia, while upholding the principles of cultural humility in practice and scholarship. So again, I will be providing an overview of the findings from 3 studies that focused on barriers. And this topic arose from nearly 2 decades of oncology nursing experience, where I've worked in a variety of clinical settings in Canada and Australia. And across these settings, I noticed that individuals facing structural inequities were more likely to fall through the cracks of our system and were consistently underrepresented across the cancer treatment settings where I have worked. Secondarily, I also wanted to begin to understand recommendations towards enhancing equitable access to cancer treatment and care for people who experience structural vulnerability. This work is informed by critical perspectives of social justice and health equity. And what does that mean? So we know that health equity is concerned with fairness in distribution and access so that people can achieve their best health outcomes. A critical social justice imperative is concerned with examining power relations that interrogates the structural conditions that create and sustain health inequities. So we have to ask ourselves, and I think many of us do in this room, despite Canada's universal healthcare system, for whom is cancer care designed for? And what are the systems and structures that privilege some while disadvantaging others? And across these studies, I use the concept of structural vulnerability to describe populations who are at heightened risk of worse cancer outcomes because of the enduring effects of structural harm. Because this is a very broad term, and for the purpose of research, I've narrowed the focus towards individuals who experience extreme socioeconomic disadvantage, such as poverty and homelessness, and have used an intersectional analytic lens that allows me to examine the complex lived experience of these social locations. So before we dive into some of the findings, I would like to introduce some key concepts that have informed this work. So first is healthcare access. This may be simple to everybody, but there is really no singular definition of this. And I have come to understand it as the complex interplay between the distribution, delivery, and availability of healthcare and the approachability of these services, and then the ability of an individual or group to obtain care to achieve their best health outcomes. This interplay is against the backdrop of the political, economic, social, and historical context within a particular society. And I'm sure in many of our locations that we are coming from, we are really seeing the political effects of how that's impacting our own healthcare systems. I'm just sure that we don't need being all in cancer care to some degree, but I'm referring to cancer treatment as approved, active, or maintenance therapies used to cure, control, or slow down the progression of cancer. So next I'll provide a bit of background. So we know from population health research studies, people who experience structural vulnerability, such as homelessness, are more likely to be diagnosed in later stages, have higher rates of preventable or screen detectable cancers, and ultimately experience much higher rates of cancer mortality. Treatment is one of the most important ways we can reduce cancer mortality and prolong life. However, research shows that people experiencing structural vulnerability are more likely to have treatment delays, receive treatment outside of recommended guidelines, have higher rates of missed visits, and discontinue treatment early, all of which can impact treatment efficacy. And we also know that these folks are underrepresented in clinical trials. So I wanted to better understand the barriers, which I've conceptualized as the modifiable factors that contribute to timely, effective, and appropriate cancer treatment. So from here, we'll dive into the three studies. The first was a scoping review, which was published. When I started my doctoral work, there were a few Canadian studies on cancer treatment barriers. And so I conducted a scoping review with Tara and Ashley, who are also here today, that we brought into high-income countries, focusing on socioeconomic disadvantage as the primary search term. The scoping review was guided by Arksy and O'Malley framework for scoping studies, later expanded by Levack and colleagues. We searched across 4 biomedical databases for primary research, screened nearly 9,000 abstracts, reviewed 130 full-text articles, and included 20 studies in the final analysis. And my ongoing joke is that this study was like finding a needle in the haystack. Of the 20 studies, 80% were from the United States. Few studies came from countries with publicly funded healthcare, just one from Canada, for example. About half used qualitative methods, followed by quantitative studies, and most focus on people living with cancer. And the results show that despite most of the studies coming from the United States, many of the barriers were not unique to that context, and instead they were strongly linked to the social determinants of health. And this included access to stable housing, geographic distance, and income supports. The findings also highlighted barriers at the level of the health system, including cancer organizations. Sorry about this. as well as interpersonal and individual factors. The review highlighted that barriers to cancer treatment are multifaceted, complex, and often compound with one another. Several studies reported that people facing multiple barriers were less likely to receive treatment and more likely to miss appointments or experience delays. And about a third of the studies noted that treatment barriers were greater for people experiencing socioeconomic disadvantage at the intersection of other locations such as race, ethnicity, immigration status, indigenous ancestry, marital status, and gender. However, none of these studies explicitly addressed the broader structural factors such as racism, colonialism, or other forms of discrimination. Okay, moving on to the second paper. I'm sorry that this is it just like keeps advancing for no particular reason. So I'll just do what I can. So the second paper in the dissertation, it was a secondary analysis of ethnographic data that was also published. So this paper provides a deeper, more nuanced understanding of the barriers in the Canadian context. The data utilized in this analysis was from a larger ethnographic study led by my supervisor, Dr. Kelly Stadjahar, and Ashley was heavily involved in this project as well, and was a pretty big mentor for me in the process of the analysis. So their original study explored access to healthcare for individuals experiencing structural vulnerability at the end of life, and it drew from 300 hours of participant observation and 147 repeat interviews. Among this, approximately 60% of the client participants who faced structural vulnerability had a cancer diagnosis. So I conducted a secondary study on the cancer code from this original data set. An interpretive thematic analysis identified the following themes. I've chosen a few of these that I will touch on in greater detail in the next few slides. So the first is the impact of lower health literacy. Health literacy affects, as we know, how patients understand and can engage with their care. And in turn, this can influence health outcomes. And implicit within outpatient cancer treatment delivery models is that people are really required to self-manage a lot of aspects of their care, which then requires a very high degree of health literacy. We know from this study mismatches in care occurred when cancer information was delivered in ways that did not align with patients' literacy levels. And this made it harder for participants to understand their treatment options, navigate appointment instructions or tests, manage their side effects. And not only did this lead to a communication breakdown, but it led to mistrusting the cancer care system altogether. It also contributed to a greater number of missed appointments, delays, or foregoing treatment altogether. And this example here, missed opportunities to build health literacy caused this participant to miss the critical window for which treatment is effective. Another key finding was that access to social care needs. So these are really the social determinants of health, like stable housing, food, transportation, phone access, and income to cover out-of-pocket expenses that are not normally covered, was critical to starting, adhering to, or completing cancer treatment. In this analysis, all of the cancer participants faced many unmet social care needs and were navigating both the social care system and the cancer care system, many without healthcare provider support, and many were also unaware of the supports available to them. Consequently, nobody in this analysis, none of the participants in the analysis were able to complete their recommended course of cancer treatment. So the third paper I'm going to spend a little bit more time on, and this was a primary research study on which was a focused ethnography on understanding the impact of homelessness and access to cancer treatment. So the data collected for the study was nested under the umbrella of a larger ethnographic study led by my supervisor, Dr. Kelly Stadjahar, on caregiving for vulnerable and marginalized adults, for which I was one of the graduate students alongside Ashley Mollison, employed as a research assistant to collect data. And because from the previous studies, we know that there are high rates of cancer in the homelessness population, I focused in on a subset of the participants that had a cancer diagnosis, and many were undergoing treatment. The data I used for this focused ethnography draws from 120 hours of participant observation and 28 in-depth interviews in one Western Canadian city. And the interviews were a mix of people who are from community-based health and social service organizations, as well as healthcare providers in cancer care, and folks who were experiencing homelessness with cancer and their chosen supporters. Why ethnographic methods for this type of for this type of research? We'll just kind of dive in on a few key things on how this focused ethnography differed from the larger ethnography. And this might be methods that you also may want to apply in some of your own work. So ethnography, it does have origins in anthropology, which emphasize observational fieldwork over longer periods of time. It is immersive and it uses the thick descriptions to look at the everyday lived experiences as well as the broader social, political, and economic and historical factors that may cause downstream effects of a particular phenomena or experience. So this kind of bridges those macro forces with the individualized or micro experiences. And I want to emphasize that the observations really allow you to gain a depth of understanding a lot of the unseen things that may not be gained in interviews. And interviews are really used to complement the observations, and document analysis may be also used. So that is a very short and high level overview of ethnographic methods. There are many textbooks on this written, and there are many different types of ethnographies. So because of my social positioning as a cancer nurse, I had an idea of what the cancer care system was all about. And so focus ethnography has been taken up by a lot of healthcare researchers, specifically nursing researchers, to focus on a particular focus based on that kind of insider knowledge. So my insider knowledge was that of the cancer system. And then look at a specific phenomenon or a subpopulation. And so really we look at that kind of, we use our insider knowledge to explore things that we don't really know about. So I was definitely, upon embarking on this research, an outsider to communities facing inequities as well as community-based research. And so observational field work, the textbooks will tell you that it is very time limited. In my case, it spanned over 10 months, although it was because I was working on that larger project, but I was kind of zoning in more on that subpopulation of cancer participants. And we did use interviews. And in this particular research, I did not use document analysis. So, some ethical considerations to consider. There are some tensions. So, to address some tensions of the anthropological roots, ethnographies are often situated in theoretical frameworks, which then serve as a scaffolding for the research process, which also allows it to remain dynamic to gain new insights. For example, we used critical social justice and health equity perspectives to attempt to challenge the dominantly held assumptions that create conditions and structures that are responsible for health inequities. And we This considers that individualized experiences of care, again, and the larger systemic forces that shape health inequities. Um, Let's see, I kind of already went through some of these things in my previous slide, but we'll just kind of move on to reflexivity. This is a really important thing in in the positions that you bring into the research as yourself. So researchers are not neutral. We bring in our own social positions, values, and assumptions into the research. So it really emphasizes this kind of ongoing critical reflection as essential to recognize how we may shape the research process or influence participants and how we affect or co-affect knowledge creation. And this is especially in the context of inequity where the power dynamics must be acknowledged and actively addressed. The terms used in ethnography, such as negotiating access, I kind of think about this as referring to the process of building ethical relationships with participants, which requires careful and ongoing engagement, especially with, in contexts of inequity, where a research can really feel extractive. The dynamic, this dynamic of it, kind of it being extractive, was highlighted in a manifesto, which you may all be aware of, for conducting ethical research in Vancouver's downtown east side. And I like this quote that states that research can be costly for our community and has rarely actually benefited us. Consequently, foregrounding the initiation of collecting data for this research um, was involved, my involvement was um, I underwent a lot of pre-training in this, and a lot of that was taken on by Dr. Mollison and Kelly, who have been doing ethnographic studies in the context of inequity and have long-standing research partnerships for over a decade. So they really helped kind of how managed how we enter this work, but also it was constant conversations kind of throughout as well. So I think that it was that pre-mentorship as well as that ongoing mentorship that really helped people who are new, like myself, in that. And then, I could get into a whole thing about reciprocity, but very, I guess, one of those things in this type of work is that we are not a fly on the wall, even though we're observing people. So doing things that you can, to build reciprocity, such as bringing in food, coffee, small necessities, helping with everyday tasks and ensuring things like interviews occur in spaces where participants feel comfortable, paying upfront in cash at the start of every interaction that really is tied not to their level of participation are a few of the ways. And just kind of having some flexibility and adaptability. Um, and yeah, just kind also taking the lead from community-based providers that have long-standing relationships with people in context of inequity. So yeah, all of those things could be talked about in much greater length, but we'll just move on for the purpose of today. Um, so the approach to the data collection started with observing the daily work of an equity-oriented mobile palliative care team. This mobile palliative care team does have many cancer clients. Um, and this really included, going out with key team members on visits with their clients, which who are living in a variety of housing sites, such as emergency shelters, transitional housing, long-term care, and on the street. It included following the team as they accompany clients to appointments, and this, naturally we would engage with other community-based health and social services in housing and other community-based organizations, and as well as the cancer treatment facility and inpatient settings. So through this work, I established relationships with a smaller number of clients who consented to independent observations. These relationships were developed quite gradually and were vetted by the mobile palliative care team and kind of working at the speed of trust. So Often it took, meeting with people multiple times over many months before, we were kind of going out with people independently. So an interpretive thematic analysis again was used to identify the following four themes. And because some of these themes are really rolling into one another, I'll touch on a few of them, and then we'll have time to explore some of the recommendations. So the first theme is this the right choice, weighing the competing priorities of unstable housing with cancer treatment. This quote highlights how cancer treatment becomes more complex for people experiencing homelessness. Some clients, upon learning of the treatment risks, declined due to fear of added suffering. Moral distress was experienced by health and social care providers. For example, ethical dilemmas arose when oncologists had to consider how treatment could be supported safely within the context of challenging physical environments, which are often crowded and where people may not have access to clean water, a fridge, secure storage for medications, or access to a bathroom. The next theme, it takes somebody, how non-traditional support networks sustain access to cancer treatment amid housing precarity. And this theme highlights the importance of caregivers in the context of cancer treatment and homelessness. Many of the folks that we work with are estranged from their biolegal family. Support may come in many other ways. In the context of this focus ethnography, it was more often community-based workers such as outreach, housing, and harm reduction workers, and of course the mobile palliative care team who stepped in and in many ways went above and beyond their roles to support folks. The presence of a caregiver was critical, and it overcame a lot of barriers associated with the environmental effects of homelessness, as we saw from the previous slide. So, in reference to this quote, this oncologist felt comfortable prescribing immunotherapy because the patient was connected to a support worker and they worked together. So, after knowledge of these barriers, it was key for me to start to identify some of the recommendations. And there are many, and a lot of them also overlap with Dr. Horrell's program of research. So I will briefly touch on a few from this particular body of work. So organizational level recommendations, and so I think because I'm a clinician, I was thought this was maybe the most salient as it might apply to some of the places where we work. And this is not really meant to be prescriptive because the local context is really going to inform, what can be done kind of and what is already being done in many different cancer organizations. So really this is drawing from this like one ethnographic study within one cancer setting. Um, I should also preface that there are many things that people are already doing to help patients overcome barriers. So I'll go through each of these domains. Um, in the top left pie slice in blue, comprehensive intake. This stems from the secondary analysis, which found that people fell through the cracks and were unable to complete cancer treatment when their social care needs were not met. So the recommendations here included conducting a comprehensive social needs assessment around the time of consultation that triggers action towards addressing barriers to facilitate timely and uninterrupted treatment. Nurses are often among the first points of contact in this process and could be ideally involved in that intake. And I think that probably, I'm not sure if this has been presented on yet, but Dr. Torrell is working on a research study, which is going to be looking at a social needs assessment tool. Next, in the orange domain is enhanced communication. So this means several things. So First, it refers to being attuned to variations in health literacy. Um, and it also refers to the communication required for care coordination. So in the focus ethnography, it was found that many folks are already connected to other care teams in community or may have other informal caregivers that may not always be recognized. This includes housing workers, neighbors, et cetera, that are doing important care work to facilitate access. So this would include, just a bigger understanding of who the caregivers are, what roles they're playing, and more importantly, documenting this in the EMR. I know there are so many times where I open up an EMR and the secondary contact is somebody's biological family member, and I call that person, they haven't talked to that person in months, and it would be really helpful just to know who are the actual support networks. And if it is not, if it's somebody in a more formalized role, like a housing worker or an outreach worker, to have just a little tidbit about people's working hours. So again, some of the folks that we were following, things like CT scans were being booked at midnight. And of course, if they're connected to a team like the mobile palliative care team or an outreach worker, who is facilitating things like transportation, that is definitely outside of those working hours. And so sometimes, these critical tests were missed or involved a lot of stress for that particular person trying to see how they were going to get to a CT at midnight. And so, documenting basically some of these basic sort of, it sounds really easy, but when it's not done, I guess it's not that easy. It's just documenting those kind of more nuanced things, in places that people see that right away, I think kind of creates a cascade, for some of that, collaboration coordination to be a little bit more smooth. And it can also create some visibility for the work that is being done in community, which can then enhance more intersectoral collaboration between oncology care and community sectors. And that brings to the next recommendation, which is intersectoral collaboration. I think this term has been thrown out around a lot in the literature, but like practically, what does that mean? I think that we're kind of at the precipice of trying to actually formalize that a little bit more, because there's a lot of informal things that are already being done. But again, if things aren't kind of formalized within, solid pathways. I think a lot of this is, again, up to key individuals that are doing things and may get lost. So, again, just coming back to the research on barriers. So when folks were navigating both the social care system and healthcare system, it was quite difficult. And we also know within healthcare, there are medical silos between specialties, community health, mental health, et cetera. So a recommendation is to foster partnerships between cancer and community organizations. This can be done in a variety of ways and honestly would be really diving into like local contexts. Um, so from the observational field work, for example, one really effective strategy was when a cancer nurse attended multidisciplinary rounds, which was hosted by the equity-oriented palliative care team. And they were able to discuss mutual cancer clients. And this streamlined coordination and problem solving. So one key example, which I think I will never forget, is I was attending the virtual rounds, which was hosted by this mobile palliative care team, which the cancer nurse had also tuned in. And they were discussing a cancer client who was actually an inpatient and hadn't actually entered the cancer system yet, so hadn't been given a consult, but was seen briefly as an inpatient for a diagnosis of quite a bad advanced type of cancer. And people, because of, kind of enduring effects of structural harm, trauma, um, the hospital is often the last place people want to be. So they come and they're often diagnosed, quite late, when, some of the symptoms are a little bit too difficult to bear in community. Upon learning of this cancer diagnosis, this particular client had fled the hospital, and the mobile palliative care team was informed of this particular person, but hadn't met him yet. So I was thinking as I was sitting there observing this, there is absolutely no way they're going to be able to find this person. And that was kind of my own bias coming from this, a place of just being an observer and thinking like how impossible this kind of seemed on the onset. And from attending weekly rounds, when I had tuned in the next week, I was very delighted to hear that all sorts of connections were made during this 1 hour. So, first, the upon learning of this person, the cancer nurse emailed both a radiation oncologist and a medical oncologist to see if they could see this person together to minimize some of that appointment burden. And so they both agreed that they could see this person the next day on their lunch break together. And to find the client, because the mobile palliative care team was in touch with this person's chosen caregiver, who was also experiencing structural vulnerability but did have access to a phone. They learned that this client frequented a local harm reduction clinic. So they phoned up that service, and lo and behold, he did attend daily. He was located that afternoon and on the phone, and they did a FaceTime, and he actually did really want to pursue treatment. He was just really scared, especially being in hospital. And so they connected with the mobile palliative care team who arranged a ride and attended the appointment the next day. So all of that was done within this connection within a 1 hour Zoom meeting, which I thought was pretty phenomenal. Um, lastly, when we look at building capacity again, it's such a broad term, but it really is just kind of building capacity for the conditions where equity-oriented healthcare can be successful. So this may include, embedding principles of cultural safety, anti-racism, trauma and violence-informed care within workflows, as well as training on the impact of substance use stigma and examining implicit bias. I would encourage organizations to look beyond the traditional ways, which seem to be employee-based training modules, and kind of create systems and processes that allow people to practice in ways that can make this work a little bit more successful. Um, Ideally, for example, this would include presence of longitudinal care providers so that trust may be built over time, which is a necessary component of whether people accept care or not. Um, and or this might be also ways of being proactive. So if we know that, for example, people who are experiencing homelessness may be at heightened risk of being in conditions that may be at heightened risk of developing more side effects because of their environmental situations, such as infections, for example. So proactively following up with folks and their support networks, particularly during, that kind of critical period within the first week or two of their treatment, where some of these side effects may be higher, and helping people manage within their own communities and maybe advantageous. This also might be things like connecting with community organizations and arranging things like telehealth in their own locations so that they don't have to come into the cancer organization, just to minimize some of that appointment burden as well. So those are a few tidbits of just things that came out of this work. Again, I think that this is really context dependent, and it's just kind of looking into the things that you're already doing and then building on the ways in which things might be able to be tweaked at the organizational levels. And so findings, further recommendations include, emphasizing the impact of roles and teams. So those are things like navigators and teams such as the mobile palliative care team that were really able to meet people where they're at in their own communities to provide on the ground support. I mean, my dream would be to create a model of care specific to oncology that could provide care and support into places where people live. Um, and this could extend beyond just providing support in the treatment setting, but also to enhance things like cancer screening and provide care kind of across that continuum. The next is making equity work through carefully designed metrics. I think we've all heard of the phrase, which is what is treasured is measured, or maybe it's measured is treasured. I'm not really sure. But all to say is that carefully designed metrics can not only shed light of inequities in our system, but can also support equity initiatives so that the impact can be measured and sustained over time. And I also think that this may be looking at different metrics beyond things like hospital utilization or emergency room visits, things like that. But things like, patient-reported outcome measures or patient-reported outcome experiences that can also track, how some of this work is being taken up. And lastly, at the policy level, the availability of safe and supportive housing for people with life-limiting illness, such as cancer, is urgently needed. So I just, yeah, encourage all sorts of, not questions, but more of our discussion would be really great. Because I'd also like to learn from all of you and some of the things that you might be doing in your own uh, jurisdictions. Okay.
Thanks so much, Amber. Yeah, that was the second time I got to hear that. So really, really exciting work. I recognize we don't have that much time left in our hour, so I'll open it up for questions from anyone on the call. And if no one has one, I definitely do. Okay. Oh,
Yeah, Amber, that was really great. Thank you so much. I think the piece that I stuck to most is probably the reflexibility piece that you were speaking of. And then also I found it interesting how like somebody had noted that like research can be costly, but then I don't see like how that benefits us. Like I think
mhm.
that's a really important point when we are doing research, but then the people that we're trying to help with the research maybe not aren't necessarily feeling like the benefits of it. So,
Yeah,
yeah.
I think that honestly, and I'll just say this, that like it's about kind of entering in a way where you're like, I might not be this research, it may be years in the making before we're going to see the downstream effects of it actually helping people. Um, I think it's being honest and upfront about that, but I think something that I really learned from Dr. Mollison, just to grind your gears a little bit, but it's just the way that we enter and the way we engage with people actually can be like transformative wouldn't be it would be transformative for yourself in a lot of ways, but you can have relationships with people that can be impactful. And so when you're having like, because again, in ethnography, you are not a neutral kind of fly on the wall. You're doing things in ways that can be quite reciprocal. And that might just also be hearing people, talking to people that allows people to just kind of open up about their own experiences. um, I think for some can be cathartic. Other people are very stoic, but it's also just kind of being like, yeah, giving people like rides, just being like helpful in any way. I mean, there's things that we did kind of throughout. that you realize you're kind of in someone's home and how vulnerable that might be. So you're doing things to facilitate. Usually, I would take cues from initially the mobile palliative care team about what they were doing, what they might need help with. This might be something as simple as like going to pack up somebody's toothbrush because they were going to the hospital, emptying someone's fridge. It's things like, yeah, running small errands. It's just you know, you don't want to stand there and be uncomfortable in a corner. Sitting down, feeling like making people feel at ease. I think it's just these small things that actually have like a big impact, and it's really bi-directional on you. It opens up your eyes as well. Like there were so many, I think, yeah, learnings that I'm still unpacking, that I think would be so nice to have like a whole Zoom just on those methods in itself. Yeah, and how engagement can be done, without just kind of saying things like, "Oh, we engaged," but how do we engage? How do we enter? You bring yourself, your full self, into those experiences, and that can also be quite vulnerable too, you know. So. Yeah, and I think the thing is, it's being reflexive on how things impacted, like your assumptions. So my example of that Zoom meeting, for example, and I was like, "There's no way someone's going to find that." Those are things that I would journal about after, and then you really see kind of how your assumptions are shaped over time. And by the end of the research project, it's like learn to assume nothing because you really don't know how things are going to. Um, are going to, you know, manifest. And, you know, yeah, it's just, I think it's a really, it's a great research method, that it requires like a lot of consideration and care, going into it. And you definitely wouldn't want to enter, I think, without like a lot of, yeah, mentorship and training throughout. So yeah, you know, throughout that whole time, Ashley and another researcher, Lexi, and I were in constant conversations. And it's just a little bit like, you know, on the fly, like, okay, this situation's happening. Like, how do I handle this? Because you don't always know the answer. And it's that continuous learning process that on how to handle certain situations as they arise. Yeah, and how to make sense of things that you're seeing, because some of those things can be really hard to see too, you know, how they impact you. And yeah,
Thanks, Amber. I recognize that a lot of people on this call are working in direct clinical settings. So I was wondering if you could just briefly comment on like what I found interesting was how your work highlighted the really important role of caregivers who we might not normally think of as caregivers and what we can learn in the cancer system from that specific piece.
yeah. I mean, I would love actually the reverse learning. Like, I would
Mm,
love more like that. I think the problem with power and paradigms really is that like healthcare providers wear a very privileged hat. And often, what I also learned from myself is that sometimes being a healthcare provider, can be actually seen as harmful, that we're not exactly the people that are the most trustworthy, even though maybe the intention is that. And it's actually learning a lot of people from people in community because there's, you know, on how trust is built, but also just like leveraging, which I know is a bit of a powerful word, but it's like there are when people already have relationships of trust,
mhm.
it's kind of thinking about that as like the primary focus of really like how to sort of enter is really through is seeing sort of that bi-directional trust because like I know in patient encounters, I often say to people when they have bring in family members, I'm always say like lightly, oh, you know, two sets of eyes and ears are better than one, but like it truly is, it truly makes a huge difference, especially for all of the things that happen after appointments as well. So when big decisions are made, and especially when there's context where it's a high pressure environment,
Mhm.
And when you're thinking about things like, lower levels of health literacy, and we're throwing a bunch of terms within a very short period of time, I think it's also following up with those caregivers afterwards as well, because they're often people that are going to be what we saw is that, if they came in with an outreach worker or a housing worker, and that there's conversations that are happening behind the scenes on how to manage things. So one of the recommendations that came from a member of the mobile palliative care team was, and also from another uh, housing site, was that they just wish that there was like a lay summary
Mhm.
on things like side effect management. So I think those like lay summaries, which, we can use technology like AI, it's just using some like technological innovation to create those types of things would be great. It
Yeah.
doesn't have to be this whole pile of work, which I think healthcare providers are pretty, with staffing shortages, burnout, all of those things, reluctant to take on more administrative roles. But it's just trying to create like systems to make some of those key things like a lot easier.
Yeah. Is there anyone else that has a question? We have 1 minute left. Ian.
Thanks so much for sharing the research that you've been doing. It's really important work. Having worked in community health for 5 years before I came to cancer care and having worked in the system for 20 years, I would say there's some really good learnings, I think, that have come out of both COVID and how we responded to folks who um, really have a lot of structural barriers to being able to access good healthcare. And I'm thinking specifically of like alternate isolation accommodations that were set up to support people. And we were able to do it then in Manitoba as well with the wildfires, devastating wildfires last year, and folks coming down. And having the opportunity to participate on some of the provincial planning calls and response calls, um, my observation and gratitude was that we were able to work together as a system when it was difficult to find patients because of all of the chaos of wildfires, but also all of the other chaos that often comes with living with structural barriers and not trusting the system. And every time, both in the COVID response and in the wildfires, it was community and community leadership that really set the tone and where my observation was that there was the most success. So I think that's what I'm hearing from you, and is just a really good reminder in terms of how we do some of this work.
Yeah, absolutely. No, that's really interesting work. And again, I wish we had more time that I'd like to pick your brain, to be honest. Yeah. Um, yeah, but
Yeah. And that is really all the time we have today. Huge thank you to Amber for sharing that work. It's definitely made me think about some things differently. I'm sure I can connect folks if you want to continue the conversation by email later. But thanks so much, everyone, for joining us. We're meeting again in June, first Wednesday in June, and hope to see you all there. Thank again, Amber.
you.